practices that they need to be updated a little bit with some to be in some ways clarify some things. I thought the CMS guidance really did a nice job of clarifying things like, clarifying and expanding compassionate care. And they offered some guidance in there for communal dining and social activities. They talked about, in more detail, some parameters for indoor and outdoor visitation. They talked about also some screening and testing protocols and how they should remain in effect, and the status of the facility with respect to outbreaks. So there's some real details in there that provided a level of clarity, at least for me, about what providers and what facilities can, how they need to think about implementing the best practices as we know them in their settings. So we're really not able to dictate, I think, exactly what people do or how they do it, but we can put out some clearer information or a little bit of more detail so that when you read the information, it sort of comes to life a little better, if that makes sense.
Okay, could you provide an overview of basically what your current guidance is providing for now, just to
Sure.
kind of give us a baseline on where we are and maybe prompt some discussion about where we need to go?
Okay, sure. So right now, the best practices for reopening to visitors in assisted living facilities kind of breaks it out into some different categories. There's like some general guidance. There's some tips on visiting, that address family members, and there's a section that also talks about personal services that take place in a facility by people who come in that aren't necessarily employed by the facility full time. So we say things like only the COVID-19 negative and the asymptomatic residents, people that meet the screening criteria, only visitors that meet the screening criteria should be allowed in. We talk about signage. We talk about designating a specific route to and from a visiting area. Of course, a central point of entry, screening of visitors and contractors and vendors. We talk about sanitizing stations, emphasize residents sanitizing their hands, the wearing of masks, all of these, the visitor log, and these sort of standard practices that I believe most of us have gotten used to pretty much where we go anywhere. And we don't get into a whole lot of detail. Well, anyway, that's what it covers. I do want to say that I think we don't talk as much about, at this point, we didn't talk that much about what residents and how to support residents, helping them, with mask wearing and some of the issues around that. I've just been really inspired, actually, by some of the things that I'm hearing that are taking place around the nation as far as how people are encouraging one another and uplifting one another to implement best practices so that we can adapt and help address the isolation. I mean, I think it's just it's something we haven't looked at until recently. Haven't had the luxury of looking at it, and it's kind of exciting, I think, to figure out how to safely do some things that our residents so definitely need to begin to be re-engaged in. So I think it's great. We talk about family members, again, designating an area for visiting closest to the entrance of the facility, restricting movement of family members within a facility, just helping to avoid any extra traffic and keeping people in areas where we know where they are and we can clean and sanitize those areas, monitor those areas for physical distancing. Think about the capacity, of course. Provide physical barriers, curtains for people, and plexiglass or curtains or dividers for people who have shared rooms or smaller facilities. We talk about supporting physical distancing as much as possible, repositioning furniture, mapping out the spaces on the floor, providing visual cues and reminders and verbal cues and reminders. We talk about limiting the number of people who could visit somebody at any one time, and ask that folks consider children. Think about if you want to have children visit, emphasize the importance of mask wearing and them being in the area and monitoring where they are and how they're doing with it, supervising them, and of course not having children that are really little, under 2, or they're not required to wear a mask, as they're not in most settings. We talk about scheduling and staggering of visits, and we talk about the duration of the visit to be shorter to reduce the potential for exposure, and we talk about maintaining an appropriate staffing pattern to provide sanitization and enough cleaning and enough monitoring and supervising. And we emphasized encouraging people to do outdoor visits. The resident's room. Visiting a resident in the room, we had talked about when somebody is bedbound, allowing family to come in or allowing them to have visits, of course, and really ask that people continue to do all of the sanitization and everything and the furniture arranging and maintaining social distances and wearing masks and all of those things. But we didn't really go into a lot about criteria for visiting residents in their rooms as far as who should come. We talked about smaller facilities, using dining areas and cleaning them out, removing all extra items, creating a more of a sense of space so that there's a little more room for air movement and room for people to be properly distanced and not be crowded. And by doing that, a simple suggestion like marking tables that are not to be used clearly, so that people don't just tend to float into them and use those spaces and inadvertently result in crowding. Cleaning and disinfecting things constantly and so forth. For the visitors, of the people who are going to provide personal services, we emphasize the use of telehealth services and encouraged it as much as possible. We allow, we talked about providing a limited number of healthcare personnel in at a time, gradually spacing them out. Certain services like podiatry, if they're medically necessary. And when there are healthcare services, we had said initially that they should be performed outside of the resident's room rather than going into the resident's room. They should be performed in a designated area, if possible. More about the sanitization. And, oh, look, pet therapy. Do you hear my cat? He's talking. Pet therapy is permitted also for people who were negative or were asymptomatic, or residents that met that criteria. And it talks about having the pet therapy activity in a designated space. So that's everything on the tip sheet.
I'd like to ask any provider on the call thank you so much for that. I appreciate the overview of what you all have in place. Any providers on the phone that could speak to what they feel they need to move forward regarding guidance, maybe the challenges that they've had, potentially trying to rely on CMS guidance for assisted living versus this tips and guidance and where they fall in between?
Hey Dana, this is Teresa Kelsey with Petersburg Home for Ladies. We were doing outdoor visitation for July and August and September. We just started indoor visitation with it being colder outside and rainy on the weekends. We have a couple of days that we have Friday for our memory care and Saturday and Sunday reserved for all the rest of the residents. They can come in, visitors can come in only 2 at a time. That's the max. And we have a separate entrance coming in the front that nobody else uses. So they have to come in that way. They have to call ahead for an appointment. The reservations for the appointments are every 30 minutes. They have about 15 or 20 minutes when they come in to actually visit. They have to come in for a screening process and have their mask on the whole time. We have a screen, a plexiglass screen in between them and the resident. So the resident is actually sitting in one of our formal areas like she's sitting in a museum. So that plexiglass screen has been absolutely wonderful for them. I know every facility is different, and this is what we worked out for us. As far as to go for indoor visitation for us, the way that our building is designed, it would be very difficult because they would have to go through the whole facility possibly to get to their resident's room. And I don't feel comfortable with that. We had a Department of Social Services, we had a Department of Health meeting this morning, and in this Crater District area that we're in, we have moved from moderate to high category of positive cases in this area, and I just don't feel comfortable with opening up to any more visitation. I think that other family members will listen to, if they know that other facilities are doing it and they have some direct guidance saying that this is what they can do, they're going to think that they can do that here. But I think every facility is different in what they can offer.
Thank you, Teresa. I appreciate that. It really sounds like you all have a really good model, best practices in place.
Hey, Teresa, this is Tara. Sorry, guys, I could not get in. I had to call in, so probably just user error over here. But I think that's a good point. And I think when we've tried to have communication with other providers, we basically say the same thing. This is facility specific. You guys have basically independent businesses. And so, I think that you obviously know best in terms of, what the scope of, in terms of visitation or any other thing really that you guys can handle. So I think that that's probably an important message, that as we move forward, we need to make sure we outline that and highlight that, because, you may not have a proper space, or may not be able to do it, or you may have other factors that determine that. So I think that's an excellent point.
Hey, this is Sharon. I have a question for the provider that just spoke, or anybody really. I'm interested in knowing how much training, retraining, reminding, it seems that that's a constant, for all of us, for our staff, for, the employees, for the residents, it's staying positive, but also just providing this information and reminding people. How much of that is going on in your facility, and how do you do it?
Well, like for our residents, the staff, they know that the residents need to have their mask on. And of course, we're always gently and lovingly reminding them, pull your mask up. And the other day, actually, when we had visitation, I have a particular person that's set aside to facilitate the visitation for our residents' families. And so even though they were on the other side of the plexiglass, she was over there with the resident, and she gave them a little bit of, privacy and everything. But she went in there and he was talking. I was actually behind them, and he was talking, and she said, you need to pull your mask up over your nose. So she was not about to let them get by with that.
Yeah, don't jeopardize my fun time. Right.
That's exactly right.
That's great. That's great. Well, I feel like also for me, what I witnessed is that how much a little gratitude just goes a really, really long way with thanking people for, taking care of each other. Yeah, so I know it's an ongoing thing. It's a constant thing. It has to be. What about you mentioned doing some screening or some assessments. Do you, are we looking at screening not only the visitors, but are we screening all of the staff every day? Do we have and what about, this is another thing I keep reading about, is travel, putting in place rules for, when employees go out of town or out of the area, or have visitors in from out of town. I know we're coming up on the holidays.
This is Teresa again. So every employee who comes in is screened every morning, and
Okay.
in every home health care provider, hospice provider, they are screened as well when they come in. We ask them to take their temperatures and everything before they even come to work, because we don't even want them to get here if they did have one. Have a temperature. So that's being done as well.
Okay.
As far as travel, I'll tell you, with everything, everybody here is scared. Well, everybody's afraid.
Uh-huh.
We've cashed in a lot of vacation because nobody's been anywhere this year.
Uh-huh.
Yeah. This is Amy Feather. I'm an ED at a community in Falls Church, Virginia. And we also do the screening for everybody who comes into the building. We also screen all of the family members and any vendors and visitors, and we have to have everything written. So all of our team members have to sign when they do the screening, and then we write and then sign for screening visitors. When it comes to time out of the building or travel, if anybody does have to travel, we have a different paid time off request form now that we did for COVID that includes gathering that additional information, where they've been, if they went to an area that's considered a hot spot, or if they traveled in a train or an airplane, anything that's enclosed. they have to take an additional 2 weeks in order to quarantine at home before they can come back to work.
Gotcha.
This is Carter Harrison for the Alzheimer's Association. I have a question for DSS. When I look at your tips, the one thing I don't see is how these policies are communicated to the families or the residents or both. And so I'm curious about how you guys are encouraging facilities to share this information, especially if it's going to be different from facility to facility. Then there needs to be a way to make sure that that's happening.
Good point. Thank you. Yes. We share the information on our website, but we don't have anything. You're right. There is nothing here. We haven't said anything we haven't provided that kind of guidance. We have standards that say that people have to disclose information. Are you talking about how we're
Now, I'm not talking about the
or
initial.
encouraging people to?
Yeah, I think Sharon,
Communicate
probably
family.
what he's asking. Carter, can you hear me? It's Tara.
Yeah, Tara, I can hear you.
Yeah, I think, we don't really typically get into how facilities communicate to their individual family members. We assume that they have something in place per their emergency plan or whatever, policies that they utilize for that. I think that could be a consideration in the tips going forward. If providers think that is indeed an issue that we, need to spell that out. I think we try not to get involved in those day-to-day types of things, but, maybe, it would be prudent for us to kind of include that, or just, possible ways to communicate. Maybe we could have a heading or a title for something like that. I'd just kind of be curious as to what other, providers on the phone would think about that, or how they would, feel about that.
Hello, this is Vivine. Can you hear me?
We can hear you. Go ahead.
Uh-huh.
Okay, I called in because I couldn't get on, and I've been trying to interject and say something for a while now, but I guess I was muted because I called in. I have a question. My concern is for many of the staff work at other facilities, and some of them work 8 hours at one facility and then rush to another facility to provide care there. So my question is there anything that is being done about that? And is there a way for you to know that you have staff that's working at more than one facility?
Is that a question for DSS or just a question in general?
Well, it's a question in general, and the reason why I'm asking that question is because we were talking about employees who travel, but I'm wondering if anyone is also considering employees who work at 2 different facilities.
So I'm not sure if April or Dana or somebody wants to chime in. I know that, one of the medical directors from a facility that had some, significant issues earlier on kind of had some good advice from the long-term care task force in terms of how to handle, those types of issues. Again, we typically, don't get too involved in that aspect of it, but I think, one, you definitely want to know who those folks are and, ensure that the precautions are being taken wherever, they may work. Because I think what we are seeing in this environment, and especially, earlier on when we had a lot of issues, and I'm sure some of you guys are still, witnessing like staffing concerns. There are a lot of folks out there that have multiple jobs in multiple long-term care facilities. So I think it's just maybe outlining some policies and procedures in terms of how you would handle that. But that's just kind of just a comment, from the DSS side over here. Again, we wouldn't be kind of telling you, how to do that, but trying to make sure that you're doing whatever you can to mitigate spread and those types of things along with our VDH partners.
Okay, thank you. I was just asking because I heard, they were talking about what they had in place for people who traveled, but I know that one facility, there was a CNA who was working at 2 different places, and she was exposed, and then she came to work, and then other people, were exposed as well because she did end up having it. So I was just wondering what was in place for that. That's all.
This is Amy again, and I was the one that mentioned the PTO policy when people travel. We also have a policy where our team members, we call it the one workplace policy that we put in place just during COVID, where they can only work at our community. And they have to reveal to us if they're working other places. And when we're doing hires now, we have something that they sign that says that they are only going to work here. And if that changes, they will notify us immediately.
Okay.
And then we also get, I don't know if your health department does it, but the Fairfax County Health Department sends out 3 times a week. They send out a list of all of the area communities that have an outbreak, whether it be staff or residents, so that you know what other communities in your area have that. But I mean, we had been collecting those names of other communities where our team worked even before the pandemic. We did it last year so that we were always aware of the other workplaces that our team is, that we share our team with.
Okay, thank you.
I also wanted to point out the chat box thank you, Lisa, for entering. She said what we do for staff who work multiple locations, they're asked if the other location has any positive cases. They ask them that during screening. And if they worked at that location in the same day as their shift with this provider, they wear a gown unless they have showered and changed clothes. And with regards to travel, if anyone travels, they're required to self-monitor for 14 days and twice a week temperature checks and symptoms checks and report any variances to employee health. So just another comment.
So this is Dana Parsons again from Leading Age Virginia, and I appreciate the questions and discussion, but just wanted to bring us back to the issue about, visitation, the discussion today about what's in place and do we feel that anything else is needed? Are there any tweaks, any additional guidance that's needed to help providers? And if there isn't, that's great too. Just really wanted to make sure we stay focused on that.
Dana, I would appreciate, this is Amy again, I would appreciate if there was some kind of standard or recommendation when it comes to indoor visits. We want to ensure, or at least what we've been aiming for with our outdoor visits, is that every resident has the opportunity to have a weekly visit with 2 family members. And I want to know if that's reasonable moving forward into the indoor, and also considering holidays. I've heard other people say, well, 10% of our residents should have a visit every day. So is there any set guidance that people are working with as far as how often each resident should be able to have a visitor?
Any thoughts on Amy's question? Thank you.
Hey,
I
this is
think,
April.
oh, go ahead.
Oh, go ahead. I was muted. I'm sorry. I've tried to talk a couple of times. April with VHB Cal, and I didn't realize that my phone was muted. No wonder I wasn't speaking, and other people started talking. Go ahead. If Burr was starting to talk, I apologize for interrupting.
Oh, no problem, April. This was Lisa. I was just saying that I think if we had a mandate on how many visitors someone were to receive a week, that would be really hard to comply with, as residents' needs and desires for visitors do vary. We do try to address every request as possible. And then what we've also done with visitation is kind of mirrored it to the nursing home requirements, where if the positivity rates are high, or if we've had a positive case in the facility or with the staff, we've restricted the indoor visitation unless it is a compassionate care visit, and those are reviewed case by case, and those can come inside to that apartment or the room. Otherwise, we do outdoor and window visits or virtual visits.
And how do you limit, according to the CMS guidance, where it says that the number of visitors in the facility at one time should be limited based on the size of the building and physical space? There's really no guidance on that. So is that just common sense that you only want a certain number of visitors perhaps on each floor at a time? Or there's several references to.
Yeah, right now, everything's reviewed case by case, so it is limited. We don't have the indoor visitation unless outdoor is not feasible. So luckily, we've been able to do outdoor for most cases, but have handfuls of residents who can't go outside or if the weather is bad. But we have scheduling systems in place where people schedule time for the visitation, and then for the compassionate care visits, those are just monitored by administration on how many total people there are, and we may ask that they come at a different time if that's possible.
Yep, and we're doing that too. I just wondered if, I feel like we are doing well, but I feel that some, and maybe it's a smaller community, maybe they're offering more visits, but it is, I'm sure any of the providers on this call get it, that with the amount of time and the need for supervision for the visits and your team, we do 3 full days out of the week. And people still would like to have more opportunity to be with their loved one. And so I just wanted to know what was reasonable, if there was any guidance on it. So.
This is Teresa again. I just think that every facility is different, and if you use the guidance from the nursing home and you think you can have that many people in, you've got to think also that if you did have a case, you had an outbreak, you've got to be able to track all of that and trace all of those people that came in. So I would only suggest that you had as many people as what you can control. That's why we only do it 2 days a week, and we have another person. We've got an extra person to facilitate that, and to make sure that all of those are being done.
Yep, and ours are outside right now, so it's good. And we do have a area that is, considered outside our community that's in our building we'll be able to use when we move it indoors.
Yeah, that is the best case scenario, is outside with a 6-foot table or whatever outside, but we are going to be at the point where we're going to have to be inside. Like this morning, it was cool, so we had to, bring it inside. But as far as what you're asking, Dana, I don't feel like there needs to be any additional guidance. If people can share information and everything, I don't think there needs to be any other additional guidance handed down by the Department of Social Services.
Yeah, and I think we just don't want to, there's just, we caution everyone about what we can and cannot do. So we can only work within the confines of what, our regulatory scope is. And so we don't dictate certain things like that. I mean, we can, and that's why you see the verbiage that we have is recommendations and tips, because, when it kind of comes down to the brass tacks of it, we aren't going to be dictating what each individual facility can do. I mean, we can help walk through it and talk about it and things like that, but I think we just, kind of want you guys to understand where we're coming from. When we put most of this together, it was, from a recommendation standpoint. And I do think that there are some things that we need to update based on the new guidance. And I think we've kind of been walking through that a little bit, and Sharon may have some of those. I know she had outlined them to me in an email as, we were, kind of looking through some of that. And so I think, there are some suggestions and updates we need to do based on just the newer guidance, especially around compassionate care, because our recommendation was, more for the end of life issues. And so I think, we need to take that in consideration and change that verbiage around a little bit. But those are, the types of things that we will and are looking at. So if that, kind of helps in terms of, where we want to lead the conversation, like what types of things when we talk about compassionate care, would it be good if we outlined with the new update and those types of things.
Thanks, Tara. Jim Wright was having some trouble getting on. I don't know if you need to *6. Jim, I put your comments in the chat box. He says, I was hoping to get some advice. I have a facility that is not allowing any inside visitation with the exception of very rare compassionate visits. These compassionate visits are only allowed when the patient is actively dying. And in order for this to occur, the ownership requires that the patient be wheeled down to the hallway to a common area. I see this as a violation of patient dignity and privacy. I have urged them to start allowing in-room compassionate visits to no avail. I was wondering what resources we have to implement the charge if my discussions with ownerships go nowhere. So I don't know if he was able to get connected, but I appreciate what you said, Tara. So, we could really focus in on what areas need to be updated.
Yeah, and in terms of his question, I think we've had a couple complaints that we've received in our office just surrounding similar issues. One issue was related to overnight visits and some things like that, but I think, always, start with, obviously management, and we can help facilitate some of those conversations because sometimes it may just be that we need to, educate them that they can, offer these types of things, and especially now. So, sometimes maybe, if you contact our office or the licensing inspector, will make sure that they, kind of understand that some folks may be reaching out just to help facilitate some of the conversations, because sometimes that's helpful. I don't know if that would, solve the problem or not. Ultimately, if there's an outbreak or VDH is involved, there's limits to what, we would be able to do, but, we can still hold folks to what is required with the visitation and the current regulations, and they have to post it and give, proper guidelines. And I know, with pandemics, kind of the first one we've ever been through, but there are exceptions and there are things that we need to look at. So, we can definitely try to help facilitate things like that.
I have two other questions, Dana. One other question is, are communities or facilities requiring all visitors to wear full PPE? And if so, are they finding that to be a drain on their current stock? And is that taken into account with inventories?
Is there anybody on that could comment regarding that?
Amy, this is Carrie Davis from Covenant Woods. We right now, in consultation with our medical director and local health department, do ask visitors to provide their own PPE, mostly concerned with the facial mask, that's in place and able to be worn, and then we would provide one if they did not have it. If there's ever a need for a compassionate care situation with an individual in isolation, we would provide full appropriate PPE to make that visit happen. Fortunately, we don't have as many of those situations, so it's not a drain on PPE that we have available. And we have a lot of visitors right now, mostly family members, that when they do come are providing their own PPE. So we've not had any negative effect at this time.
Thanks, Carrie. And we do the same. We provide the PPE. That's just, I mean, I'm looking at this message from Jim Wright, and I just think I'm trying to imagine under what circumstance a community would deny a family to have the opportunity to be with their loved one in the privacy of a room during this time. And that's one of the only things I could think of.
Yeah, and I'm on now. Sorry. Can you hear me? This is Dr. Wright. Hello?
Yes, we can hear you.
Yeah, we
Oh,
can hear
great,
you.
great. Yeah. Yeah, so I am a medical director for a number of assisted livings, and one in particular I'm trying to kind of urge towards in-person visitation with all the appropriate distancing and masking and all the checklists and everything. And I've been unable to help them to get to that point. And you read about my, I'm sorry, just got on, but I'm assuming you read about my challenges with compassionate visits as well, in-person compassionate visits.
We did. Yeah, we have that information in our chat box.
So what is my, how, practically speaking, what can I do to help move the conversation along if my efforts are not successful?
And I just want to clarify this, April, Dr. Ray, just want to clarify your efforts being, as a medical director, providing guidance and what
coming
you
up,
recommend, given,
yeah.
and you're also taking into consideration, I'm assuming, the facility itself and any current outbreak situation.
Outbreaks,
okay.
right.
Okay.
Mm-hmm.
Yep.
Yeah. So I'm pretty good with helping the facility keep up with all the current regulations and the very helpful guidelines from the DSS. And even, I came up with a recommended protocol. The facilities in an area with low prevalence, and no outbreaks or anything like that. So it's the pushback I get is that, and I'm not sure this is true, but the pushback I get is that no other assisted livings are allowing in-person visits in their area. And I guess that's would be helpful for me, another piece of information. Do you all have any information as to what the percentage is of assisted livings that are allowing in-person visits? Is there any data on that?
I'm not aware of any data source or anybody who's been collecting that data that could actually give an accurate percentage. And I especially think that because it is, that they're looking at the percent of positivity as well as what is currently going on in their facilities and testing dates being various, whether a facility is testing on a Monday and the facility next door is testing on a Thursday, that could very quickly change. I think, we have a lot of great providers here on the phone who shared, their current experiences, but I think it's a matter of resource and what do they have on hand. And I heard PPE just brought up that, do we have plexiglass? Do we have rooms dedicated within facilities? And while we don't have concrete guidance on, X square footage of a building should have this space designated, or if there's, from the front door to that space, this is the number, the amount of feet that they're traveling, and they're also not, interacting with the, other areas within the building. I think that there was a little bit of hope from this group that there could be some more guidance around those kind of parameters. But I do think and I heard Tara several times say, what DSS, what they provided is guidance, but there is really no, there's no, one size fits all. I hate saying that because I think at this point we're all getting tired of hearing that, but it's true. What I do know is that everybody is striving for ensuring visits are occurring, but they want to make sure that they're happening and there's no negative outcome from it. So, you know, I guess it's really, I'm stoked to hear that you've worked and you've provided, you know, that type of assistance for our, you know, for assisted living facilities, because again, where they don't have medical directors as the norm, that's, you know, they're, you know, facilities are really left to their own devices. So that information could be helpful. I don't know, Dana, Melissa, what you think, or even Tara, but that could be helpful as a starting point for, you know, providing, you know, additional kind of more in-depth guidance. So that's great. But not an answer by any means.
Yeah.
Dr. Wright, this is John Burns. I'm the CEO at Westminster Canterbury here in Richmond, and not knowing anything about what facility you were referencing, but here at Westminster Canterbury, we reopened visitation really at all levels in a very structured, process-heavy, instructional kind of way, where we're letting in-room visitation in all levels of care, with some limits, but not the limits that everybody else has mentioned. And I was reluctant to even bring it up because we're doing it very different. I mean, we've basically said families need to see their loved ones, and we need to put structure around it. And the compassionate thing to do for all of our residents is allow them to see their families. And then we need to spend the time with the families to say, you have to keep your loved ones safe and wear PPE and keep your distance. And I mean, 100% of the time we've seen families comply, and we've seen a lot less visitation than we expected. We had a little bit of a rush when we first opened, but in both in assisted living and in nursing, but then it really slowed. And people are fearful and they want to see their moms or dads, but they don't want to come every day, at least most of them. So I think if there's an angle to take with ownership, it's just, you know, if you put process in place and you have to supervise it to a degree, you can do it safely. And it's all with the caveat, a case shuts it down. And as soon as we have a case, and we might, we're going to shut it back down. And it's gone really, really well here. That's good. So.
And I think that, you know, that kind of information does help. You know, if I'm able to bring back to the ownership that and by the way, Our Lady of Hope is doing the same with their assisted living. If I'm able to bring back the information that multiple facilities, well-respected facilities in the area are doing it, that does help. So thank you.
So one of the things that I'm hearing from today's call is that hearing some really good models and best practices and some potential areas that the department may want to tweak and place some emphasis on in their guidance. But I wonder, you know, do we need to continue to have this call and discuss these issues so that the department hears what providers are struggling with? You know, where does the group want to go from here?
Dana, this is Amy. I think it would be helpful to have this call, and it may not have to be specific to visitation, but I think being able to translate some of the guidance from the state, from CMS and skilled nursing to assisted living, I think it would be great for, I know Judy at VALA gives me some additional input, but I think it would be nice to hear from DSS what their areas of concern might be and what our questions might be.
Okay, thank you.
Dana, this is Dana, and by my suggestion, we have the time to do this, but I'm just wondering if we would plan or maybe plan for some type of webinar or something for folks. And I'm thinking maybe not so much even the folks on this call, but I know we all realize that there are providers out there who don't have some affiliations and struggle with, you know, writing some policies and procedures. If we could get, you know, just maybe some folks in place to kind of help walk them through that, what it may look like, what would help, you know, and those types of things. I wonder if we kind of went from a more of an educational standpoint that we would be able to, yeah, I don't know. You know, it's just a suggestion for the future, near future. As I'm sure Sharon S. and Sharon Lindsay on the call are probably like going, really, Terry, you're volunteering us, you know, for something else here, but would like your thoughts.
And Dana, I don't know if you can hear me. I've been kind of stuck on mute.
Oh, we can hear you, Joni. Glad you could join.
Okay, I've had the same problem as others, and I couldn't join the other route, so I finally tried the phone. No, and I appreciate what Tara just said. I was just going to follow up essentially with that same thing, but based on, you know, the comments that Dr. Wright made and John Burns, and I am thinking, boy, it could be, it's one thing to issue guidance and recommendations, and that is all, I think, really important, but to actually have, you know, the voice of someone who, you know, for example, either Dr. Wright or John Burns or others that have talked about what's working for them, to really do sort of an in-depth explication of how they've approached this, you know, down to some very practical steps. One of the things that we hear so often is, you know, from folks that we're working with, including administrators, is just some confusion and not feeling secure about, you know, taking the risks and opening up. And I think so much of it is in the specifics, the details, the logistics of how you do it, and the sort of just systematic process, so you don't feel like you're just opening up to willy-nilly infection introduction to the community. So I would really love to see something of that sort if that seems beneficial to the providers above all.
Yeah, Joni, this is Dr. Wright. I totally agree. I think if there was a kind of a compendium of best practices that other facilities could look at and say, well, this is up on some official website, DSS's website or something like that, and they're obviously okay with that or something, you know, it would give facilities like mine I think, reassurance that, well, if we follow those particular pathways, clinical pathways or visitation guidelines, then we should be okay. So I think there's always safety in numbers. No one wants to be the first one. And I think, you know, in my particular situation, that's the problem. We don't want to be first. So knowing that there are other people out there doing it would really help. That would be very helpful.
Okay, well, we have 5 minutes remaining. I think if folks would like to share information with me, models, best practices with Leading Age Virginia, we can certainly compile that information and make that information available to everyone, and work with the department and maybe placing that information on their site. I don't want to speak for them. But I'd like to hand it over to DSS just to see basically in what you've heard today, what direction that you all would like to go in.
Okay, well, no pressure, Dana. Thanks. You know, I think I would like to kind of get feedback on, you know, maybe what we could do. I think Dr. Wright kind of had a good recommendation, and I think if we can, you know, maybe get some information on our site, we're willing to do that. But I mean, we just kind of want everyone to know we're here for, you know, for you guys to be a resource. And so, you know, I kind of would prefer that you guys say, you know, this is what we need from you, and how can, you know, how better we can help, you know, facilitate information and guidance to you guys, understanding that, you know, whatever we do would be, you know, a recommendation or best practice type of things. I don't know. I know I've got Sharon Lindsay and Sharon Strobel on the call. Do you guys have anything to add to that?
Hey, this is Sharon, and I've been taking some notes, and I'm incorporating them into hopefully updating. I'm gonna draft a little something, and we can maybe update our tip sheet a little bit and make it bring it along into the current way things are looking right now, and I think the communication is really important ongoing. I think we still need to have these talks, because otherwise we won't really know what it is that the community is finding useful and what's working for them and what's not. Because that alone is really valuable information when I talk to other providers and inspectors. So yeah, thanks.
Well, thank you, Sharon and Tara. If anyone on the call today wants to send me information about recommendations for tweaks to the guidance, any models, best practices, anything that you would like to share, I'll compile that information. I'll take any community identifying information off of that and get that to the department. As far as there being a second call, I guess we can consider that, and we'll let the group know. I do want to be respectful of everybody's time, so we have 2 minutes remaining. Is there anything that we haven't addressed that you'd like to address?
Dana, this is John Burns. At the risk of totally overcommitting my team, I'd be happy to share what we're doing. I don't know if you can describe it as best practice, but it's our practice, and there's nothing magical or special about it. It's just process. But we'll pull together what we're doing and share it with you, and then you guys can use it if you want.
Thanks, John. I appreciate that. And anytime you send information, if you do not mind leaving your community on it with a contact so that other providers can follow up with questions, that would be great. Okay, well, thank you everyone for your time. I will look forward to hearing from everyone about information to provide to the department. And if we have a second call, I will follow up to let you all know. Thanks so much. Have a great afternoon.
Great. Thank you.
Thank you.